this is Jacqueline from Lichen Sclerosus Support Network, where our mission is to empower people with lichen sclerosus by providing evidence-based education and support so that we can live in a world where those affected by lichen sclerosus are empowered, informed, and educated. If you find the information in these videos helpful, please consider donating your time or money so that we can continue creating LS education and support efforts. So today I am incredibly excited. We are joined by my dear friend, Mukta Chauhan. She's actually a returning guest. She's been on our channel before to talk about overactive pelvic floor muscles and pain with sex. If you haven't watched that video, I highly recommend it. We'll leave a card up at the top. We'll also have that in the description box below for you to check out after you catch this video. Now, the topic of today's video is one that doesn't get a lot of attention when we look at LS content on the internet, but it's one that's very in demand, and we are going to talk about something that a lot of us struggle with, and that is constipation, having bowel movements with lichen sclerosus, specifically vulvar lichen sclerosus. That's what we're going to be chatting about today. So we are going to talk about why is constipation a symptom, how does this manifest for people with LS, and then we're going to move over to some practical advice. So how can we manage this? How can we be more comfortable having bowel movements? Practical tips for managing this. That is what this video is all about. So we're going to jump into that. Of course, as always, be sure to like these videos, subscribe to our channel so that you don't miss out on any more LS content. And with that, let's jump into things. All right, so welcome, Mukta. It's lovely to have you back with us here at LSSN, and I'm very much looking forward to having this conversation with you because it is something that we get asked about so often in support spaces, and there's very little resources on this out there. So we were actually going to film a completely different topic for this, and last minute I kind of threw it at Mukta. I was like, hey, can we talk about poop instead? Because there's so many questions and so many complications, and there's a huge need for that. So thank you again for working with us and happily accepting to change the topic last minute. So before we jump into our theme of the day, I'd love for you to just say a little bit about yourself, about your practice, and then we'll talk about bowel movement.
Thank you, Jacqueline. And I'm always happy to talk about poop. So, I'm also happy to talk about central sensitization, but poop is something that I think a lot of people struggle with. And the more I have been working in pelvic health, I realize, wow, so many people are constipated in the world and nobody talks about it. So it's been an eye-opening fact for me. But just a little bit about myself. I am a pelvic health physical therapist. I'm double board certified in orthopedics and pelvic health, which kind of gives me a really nice, well-rounded edge is not the right word, but well-rounded kind of, perspective to really see my patients from a whole body perspective and not just kind of narrow down to just pelvic region, because as we know, different systems work together in the body, and pelvic floor is heavily dependent on what's the status of your nervous system, what's the status of your musculoskeletal system, heavily depended on the health of our hips, low back, our core, our breathing, and so many different things. So it really helps me to assess my patients from a whole body perspective. I practice in New York City, Manhattan, and I have my own practice, which is the Pelvic Connection Physical Therapy. And I think that's pretty much about it. And I see patients with all kinds of pee, poop, pleasure, all kinds of pelvic floor issues, but not just limited to pelvic floor. Sometimes they come in with hip pain and I find the pelvic is involved, and vice versa. So work with different kinds of aches and pains and chronic issues, including lichen sclerosus and constipation. So let's talk about that.
Yeah, definitely. So constipation is something that kind of gets overlooked in the lichen sclerosus space. So even if you read a scientific paper on lichen sclerosus, usually at least the introduction will kind of give a broad overview of what LS is, and that'll typically include a little sentence or two on symptoms. So what are the common symptoms that people experience? When you read through these papers, they're always talking about vulvar itch, pain, and pain with sex. Those are the main ones that kind of get highlighted. Maybe they might mention burning, aching, soreness, and that's kind of it. But that's a little unfortunate because constipation is quite a common symptom of LS, and it's something that we often forget to talk about. Even me as a content creator for lichen sclerosus, it often slips my mind when I'm writing up those symptom things that, oh, right, constipation is one. So one of the reasons why people with lichen sclerosus may have constipation issues depends on where they have lichen sclerosus. So you can have lichen sclerosus just on the vulva. You can have it on the perianal skin, so like around the anus, or you can have it in both. And honestly, constipation can come into play with any three of those, but especially if you've got involvement in the perianal area, because you're going to have symptoms like pain and fissures and burning, tearing, itching in the perianal area, which means that when you go to the bathroom, it's probably going to hurt. And what happens when it hurts to poop? We guard, we brace against it. We may even try to avoid going, just something I've done before.
Yep.
And we might get ourselves into a hyper stressed state. So as someone that experiences like anal fissures myself, I have so much anxiety and stress bound into going to the bathroom. Every morning I dread it. My nervous system, I can feel it ramping up because I know the pain that's going to come, which then, involves bracing and stressing. And it's just this perpetual cycle. And this can happen too, even if you have vulvar lichen sclerosus but don't have it in the perianal area. Again, it all has to do with that bracing, that guarding. And another thing I just wanted to mention quickly with constipation as a symptom is this is very common in children with lichen sclerosus. So in the pediatric journals, they actually do include it as a symptom. In fact, they talk about it being one of the main symptoms for pediatric lichen sclerosus is constipation, and that's something that parents are kind of told to monitor for. So it's definitely present in both children and adults, which is why I wanted to talk about this today. And I thought I would start us out really simple by having you just explain to us what is constipation and what is the role of the pelvic floor. And the reason I wanted to start us off with what is constipation is because, to your point, so many of us are constipated and have no idea that we are. It's really mind-blowing. So let's start off simple. What is constipation and what is the role of the pelvic floor in constipation?
I think you summed it up really well, like how involvement of the pelvic floor because of the presence of LS in different areas can eventually lead to constipation. And anal fissures is actually one of the common things that we see anal fissures can happen for various reasons. But if the skin around the perianal region is not stretchy and it requires a lot of expansion and opening of the anus, if that tissue is not flexible enough, then of course tearing can happen, just like how the tearing happens in the vulvar tissue. But just to answer your first question, constipation, generally speaking, constipation, it's very interesting and it can be a pretty vague definition. Usually the way normal bowel movement is described is you can go to the bathroom anywhere from 3 times a day to 3 times a week.
Right.
I have come across many people who get super anxious about not being able to poop on every single day. And this is what I tell them, we just don't look at the frequency, but we also look at the consistency and the type of bowel movement. So if it is mostly, there's a whole Bristol stool chart that people can check out. I forgot to print it out, but
we'll pop one up on the screen.
Yeah. So basically, it's kind of a lumpy, pebble-like bowel movement, absolutely clearly you would know that you're constipated. And the harder the poop gets, the more difficult it is to pass. And then if the anal tissue is either thinned out or it's, loses its flexibility, it can create anal fissures and then kind of like creates a cascade of symptoms where tightness, the fissures cause pain, then guarding, then tension in the pelvic floor muscles, then it can create stress, then more tension and guarding, and so on and so forth, and it kind of perpetuates. So people who go less than 3 times a week, but it's not like, oh, I go 3 to 4 times, but my poop is lumpy, then you are still constipated. So it is about the frequency, it's about the type of bowel movement, it's about the ease with which you are passing the stool. If you feel that you passed it, but you didn't feel that it was completed, there is incomplete defecation, or if there is pain that you experience with pooping. All these things can contribute or can kind of point to you having constipation. So that's just the definition of constipation. Now talking about the function of the pelvic floor muscles, I'm sure your audience, have read many of your blog posts and videos, and they know exactly where the pelvic floor is. But for uninitiated, let's talk about, here, this way. So the pelvic floor muscles are a group of muscles that it's kind of, the camera is opposite. So
yeah, I know,
kind
it's
of
weird.
confused which way to turn it. So anyway, the muscles are sitting inside the pelvic bowl. It's not just one single muscle. They're a group of muscles. And the muscles you're seeing right now are what we call deep pelvic floor muscles. They are, they're situated like a trampoline or a hammock supporting all the pelvic organs. But then we have more superficial pelvic floor muscles as well, which have more sphincteric action. And what does that mean? This way. It means that they support these superficial, very small muscles, support the opening and closing of the urethra, opening and vagina doesn't really close, but it can contract, like it can become smaller and expand bigger. So that's also, controlled by the superficial pelvic floor muscles. And then your external anal sphincter, it is also a superficial pelvic floor muscle. We have another layer in between, which is difficult to palpate or difficult to kind of see. It's more in the urethra. There is, and kind of like in between. So we kind of, let's not go there. It's just good enough to know that there is superficial pelvic floor muscle and then the deep pelvic floor muscles, which are bigger and they support some of the pelvic organs. So what are the pelvic organs? The pelvic organs are, in people with vulva, there is a bladder which sits right behind the pubic bone, which is right here, this white thing. The uterus sits right on top of the bladder. And then you have your rectum, which sits right behind the vaginal canal, right behind the uterus. So they're kind of like nicely packed organs, the pelvic organs. And they are supported and stabilized in this pelvic bowl with the help of the pelvic floor muscles. So just a little bit of introduction of the pelvic floor muscles, but we are particularly interested in this one specific muscle when it comes to bowel health. And that muscle is puborectalis. The puborectalis is one of the innermost, I have written the name as well, maybe it's the other way around, but there. So it's the innermost muscle that kind of goes in a U shape, and this is the exit point for rectum, this little dot, and it kind of goes around it in a U shape. So the way it looks like is basically this. So imagine this is a band of the muscle and it goes and hooks around the rectum. And basically it connects to the pubic bone in the front and goes all the way to your rectum. Like the rest of the deep layer of pelvic floor muscles, this specific muscle does not go and attach to the tailbone, which is right here. Why it is important to know, just to kind of, tailbone can actually affect this muscle as well, but it is slightly different than the rest of the muscles, that it doesn't have a direct attachment to the tailbone, although we do use a lot of tailbone movements in order to release it. Just like a little tidbit about the muscle. I don't think it's super important for you guys to know. But so if this muscle is very tight, as you can see, it kind of hooks it. And the reason why it hooks it is to keep us continent. So it doesn't leak all the time. It's not, the exit point of the rectum is not open and kind of like just keeps leaking feces. So to keep us continent, this muscle stays in a little bit of a tense place. So a lot of people also think that pelvic floor muscles need to be always fully relaxed. That's not true. Even at rest, they are always working a little bit. They are considered postural muscles. Right. So just like your core, your back muscles, they're always slightly activated because they're working constantly to keep maintain the continence, not make us leak with different activities, and also support the posture and breathing. So in order for you to poop, this muscle needs to expand so the kink in the rectum can straighten out and aligns with the external anal sphincter. And as you push from the top, as you're kind of like, applying the pressure, the anal sphincter expands and the poop comes out. So this is basically the pooping mechanism and the role of the pelvic floor muscles in it. But as we know, the pelvic floor muscles don't work in an isolated fashion. It's not like the puborectalis is working on its own. It is working with the rest of the pelvic floor muscles as well. So let's say if you have tightness in the front part of your pelvic floor because of vulvar lichen sclerosus, the pelvic floor muscles attach from the pubic symphysis, behind the pubic symphysis, and go all the way to your tailbone and sacrum. So they could be tense either at the point of origin, at the point of insertion, in mid place, in the mid belly of the muscle, or if the tension starts in one place, it can eventually go to the other places in the muscle, especially if a condition is chronic. So it is possible, and it is seen clinically that, I always ask, like, how's your bowel health? And sometimes my patients with overactive pelvic floor, whether they're coming for LS or urinary issues, when I ask them, they may say like, oh, actually, we don't have an issue, but eventually they can develop it. Or some people actually come with clear signs of constipation, and as constipation improves, a lot of their bladder or vaginal symptoms also improve. So since these organs are kind of sitting in such close proximity, they absolutely influence each other. So if one system is not working well, this is the end of your bowel system. This is the vagina is kind of like where the reproductive system kind of ends, and the bladder and urethra where your urinary system is working. So all these systems influence each other, and the pelvic floor is kind of placed right under it. So if there is any tension in the pelvic floor, it can definitely influence any of these symptoms or all of them all at once. So I hope that was clear with the pelvic floor's function. So when we treat or when we talk about constipation in the clinic, in the office, we want to make sure a few things. Whether the constipation is happening because the gut is slow, if there are other gut-related issues, because here we are just talking, when we talk about pelvic floor, we are just concerned about the very end part of the entire GI system.
Mm-hmm.
But we're not, this doesn't tell us what is going on up above.
Right.
So how is your gut motility, how different organs are working, if you have bloated, other symptoms, IBS, if you have been diagnosed with IBS, etc., could also give us some information in the sense that, oh, okay, so your gut is not working with the regular, the travel time of the poop from the small intestine to your large intestine is very slow. So obviously, the longer the poop stays in the colon, the more water is going to be drawn out of it, and it's going to become hard and lumpy, and that's going to be causing difficulty for you to pass it. And then the more you strain to pass the bowel movement, the strain goes to your pelvic floor, and the pelvic floor can get tense. So the problem can occur from top down or bottom up in both ways, or sometimes simultaneously. So some PTs can assess like how's the visceral health of your different gut organs. But if you've seen a GI doctor, you worked with someone, definitely present this information to your pelvic PT so they can include that in their treatment as well. But for the lower part, what we call it generally, or there is a specific term for it, is called outlet obstruction constipation, which literally means that the outlet is obstructed in one way or the other.
Right.
And that's what's resulting in this difficult defecation. So obstruction can happen because of this tight muscle, which is kind of, this puborectalis is like really tense and staying in this, keeping the the end of the rectum very kinked, so it doesn't let anything come out. Or you have to strain super hard to combat that tension. So you may feel that you have to strain a lot. But what happens with straining is, as you strain a lot, it clamps your pelvic floor even further. And having said that, reminds me of another issue, which I see a lot of people with constipation, is clenching of their belly. This guarding, this clenching, this kind of this coping mechanism to kind of combat the pain that you're experiencing because of fissures or any tearing down there, can also restrict your breathing. And that could happen because of tensing of the abdominal muscles right at the top of your belly. So it can restrict this free movement of the lower rib cage, which can also restrict or limit the optimal functioning of your diaphragm. And diaphragm has a really important role in gut motility. So you see, like, it's kind of like a cycle. So one thing can affect the other. So we have to really assess the whole system. How is your breath? How is your rib cage mobility? Are you clenching in your abs? Because a lot of things, just like any other, if you just go for overactive pelvic floor to a PT, we talk about breathing all the time. And I'm sure you have read about breathing, like breathing is important. So improving that diaphragmatic function can really help with improving the motility of all these organs as well, because diaphragm is always constantly doing this motion involuntarily. You're not controlling your diaphragm. And I don't remember what is the number, like thousands of times it goes up and down. And with this kind of a nice massage and excursion of the diaphragm, the gut stays stimulated and the motility stays optimal. But when you're like kind of breathing very shallow, you have tension in your abdominals, things will move very slow through your different, your intestines and finally to the colon. So can make the bowel movement very lumpy. And then you try to pass it, and so it's kind of like going.
Yeah.
So we have to really take care of, really have to assess what's going on at the gut level and what's happening at the rectum level as well. I guess that's, I don't want to, it can go, I can
Yeah,
go
I'm sure.
round and round with this.
No, but this is part of the reason I wanted us to start with what is constipation, because I just learned so much. I thought I knew, like, first I had no idea what constipation was. Then I felt like I kind of understood it a little bit more. And now I'm like, holy, like that is so much more complex than I realized. And I love that you always emphasize the interconnectedness of all of our systems and parts, because it really is so important. So with that, I'm curious to know, let's say I'm a patient, well, I am, but I have LS and I have constipation and I'm in Manhattan and I come to see you specifically for constipation issues. What would my first visit look like? Can you walk us through what that would be?
Absolutely. But before I say that, I forgot to mention one more thing. A lot of people think, some people can also have loose stools or watery stools. And they may think that they actually have diarrhea and not constipation, but that is also a sign of constipation. So if you are getting intermittent loose watery stool in between pebbly BM, that's also an indication. And that usually is a sign of impacted stool, meaning the pebbly stool is kind of collected in your colon. Sometimes it can go all the way to your, descending and transverse colon as well. It can be seen in an MRI or even a flat plate X-ray. That's usually can show impacted stool. And this is not to scare anyone. It's not like if you have that, oh my God, like, it's the end of the world. There are ways that it can be improved. And usually the doctor might give you Miralax or something on a regular basis, like an osmolytic laxative, or sometimes they even give you a colon prep to kind of clean out, because you could be doing everything to resolve your constipation, but if you have impacted stool, it can be very difficult to kind of win over it. So it's like you have to kind of clean out the system first, flush it out, and then start with all your different exercises and everything, fiber intake, water, all those things that you need to do for that. So keep that in mind, that sometimes loose stools can also be a sign of constipation. So a typical visit, how it would look like is, again, I would take the history, what, all kinds of medical issues that, and each person is having. I usually ask them if they were constipated as a kid, because it's very common, and nobody asks kids. Nobody asks adults about their childhood history. But it can, childhood constipation can, it's almost like it could put you in your pelvic floor in a place of like a predisposition to overactive pelvic floor.
Interesting.
Which we see a lot. So like, people say, I don't know, I just had this yeast infection, or I'm kind of like taking a segue, but I just wanted to say it. Like sometimes people like, why person A didn't have any overactivity with their pelvic floor with yeast infection, but I did. So you have to kind of really go back into the history and see if you were ever predisposed to having an overactive pelvic floor for any reason. And it's symptoms take time to build, and it didn't happen overnight. So knowing a little bit about your childhood history, your teenage, how are your periods, and how it impacted you overall, can really give us a lot of information. So I take all that information, and then as far as the assessment is concerned, again, I check the breathing, rib cage mobility, if they are tensing their abdomen, if they have that strategy for any reason. Then it comes to their pelvic floor mobility. So I obviously, after taking their consent, check them vaginally, and then rectally as well. A lot of times I have found that they may not have tension in one area, but may have tension in the other. Having tension vaginally doesn't always mean that they will have tension rectally also.
Okay.
And having tension rectally doesn't mean that they will have tension, although we're talking about the same muscles. However, the puborectalis muscle that I spoke about in the beginning is mostly easily palpable rectally. I don't think you can really assess its function vaginally, because you really have to see how well the person is able to contract and expand this muscle. And you feel that opening and like a real nice expansion all the way to the internal and external anal sphincter. And that's what we are looking for. Do they have the right mechanics to poop? A lot of times people think they're straining, but they're actually straining and pushing down.
Yeah.
But they're instead squeezing, and they don't realize this. So this is a very typical thing in outlet obstruction syndrome, as we call it, outlet obstruction constipation. And this is something I want to tell people, that if they have constipation, or sometimes it may present as tailbone pain, that they may not even think about that constipation is happening, but they're like, I don't know, I just feel this pressure on my tailbone all the time. The tailbone and rectum are very closely related to each other. Rectum is sitting in front of the sacrum and the tailbone internally. So I really believe, not right away, because people don't feel comfortable and I don't want to aggravate anything or disturb anything, but I do eventually check my clients rectally as well, just to see overall what is going on. There's so many structures in the back passage that we cannot check very well vaginally. So if you haven't had an exam yet, you could ask your PT, to perform one to get more information, and then basically make a plan. So yeah, vaginal exam, rectal exam. Sometimes I do a balloon manometry, which can, give me 1 second. So some people, when they're having constipation, to really determine if constipation is happening because of the gut motility issue or something with the GI system versus it is outlet issue. There are a couple of tests that are done. One of the tests is called balloon manometry. And a lot of times when people don't really know that pelvic PTs can help with constipation, so they usually go to a GI doctor or a colorectal surgeon if they have fissures and hemorrhoids and stuff like that. And usually to determine that, the doctor would do a balloon manometry test, which is basically inserting a catheter anally and kind of inflating it with a syringe which is outside the body. So you're just kind of, you inflate it, and then the idea is the patient is supposed to push it out, and they have different monitors that check the pressure at the internal sphincter or the external sphincter, and just the overall activity of the pelvic floor muscles. And if the pelvic floor muscles are the tension is actually increasing instead of decreasing, and anal sphincter is becoming more tense, that's how they kind of determine that it is an outlet obstruction issue. And that's when they refer them out to a PT. So this is, again, like, I haven't used this very commonly because people are like, okay, what is that? Although it is thinner than my finger, so it's less of an issue. But it could be down the line, you've done rehab, you've been doing your exercises and relaxing your pelvic floor, you're doing breathing exercises and everything, but then you're like, I don't know. I can relax my pelvic floor when I am doing the exercises, but my brain still doesn't connect to that part when I'm actually pooping, and I end up always tensing up. So this could be a really good tool as a feedback mechanism.
Yeah.
You're basically also helping them understand when the urge arises, because a lot of people are completely disconnected from that
Yes.
part. If you especially have pain, you don't want to think about it. So
Yep.
slowly that understanding of when the urge occurs, you're like, oh, I don't know, I don't have to go. It could be another coping mechanism of not want to feel the pain, so you're like avoiding, and you're like, yeah, I don't get the urge, so by connecting it to, so basically it's just like we increase the air in the balloon very, very slowly and
Yep.
ask them, can you feel the urge now? Can you feel the urge now? Because rectum, interestingly, only has, especially the lower 1/3, I think it's after there's a dentate line, anatomically speaking,
Right.
and the rectum only has pressure receptors, not really pain receptors, as far as I know. And so basically the rectum is a really good storehouse. When it's really full of poop, that's when it triggers like, oh, I'm full. And that's
Yeah.
when the urge goes to the brain, and the brain is like, okay, find a toilet because you need to go.
Mm-hmm.
Because of this, but it is a stretchy organ as well, and if it's not storing, it can push back the poop to colon, to sigmoid colon and the descending colon, and that's how the impacted stool kind of stays
I see.
in the system. So in order to really make a healthy bowel movement or help the client to understand that they need to go to the bathroom, we work on helping them feel the urge. So
Mm-hmm.
slowly we build it. So maybe they will feel the urge at a higher pressure, and then slowly it decreases down and becomes more
Yeah.
normalized. And then we ask them to kind of push it out. So it gives them a little bit of an understanding of like, okay, pushing is
Yeah.
with the breathing, with the exhale, you're kind of trying to expand the anal sphincter and not clench it.
Mm-hmm.
So kind of like mimic the BM
Yeah.
thing in the office. So balloon manometry is a test and a treatment
I
as
see.
well. So yeah, I mean, in terms, and you can actually, a PT can generally feel the tension in the puborectalis muscle. You will feel the tailbone is kind of like really
Mm.
clenched forward,
Right.
pulled forward because of the tension in the pelvic floor in the back part. And as you're kind of helping release the muscle, you may not even need to get to that point. And once I sometimes, it's kind of like, if my finger is inserted rectally, I ask my clients, can you bear down, can you exhale and try to expand this? And when they're not expanding and actually tensing my finger, I give them the feedback, you're actually tensing. So give them
Yep.
different ways to work on it. One of the favorite ways to help improve the expansion is making some deep guttural sounds like or
Mm.
moo to poo, is a very
Yes, I've heard that.
yeah. So we could do that, but we really discourage them to hold the breath and do this
Mhm.
kind of a thing, because it clenches everything from your abdomen to your pelvic
Yeah.
floor. um is this good? Like you're
Yeah,
because
no,
I'm
that's great. I have a quick question about the rectal exam,
yes.
because I think some people might be like, hold up, like we've spoken about vaginal exams, but rectal exams? So finger, glove, lube, how does that work? Just to kind of
um
set expectations, because I think people might be a little bit more apprehensive about that one.
Absolutely.
So I think like, full transparency might be good so they can kind of set
Yeah,
their
absolutely.
expectations.
And there is no way I can sell a rectal exam to a client. I think they only want to do it because they want to get
It'll help
better,
them
and
get better,
it would
yeah.
help
That's what I
them.
was thinking.
uh yeah, like it's not pleasant, and I tell them right away, it is not going to be pleasant. It's going to feel
Right.
like you have poop in your rectum, because guess what, the rectum
Yeah.
is going to feel the pressure of the finger, and it's going to like, I don't want to
Mhm.
I don't want to make a mess here, but I tell them like, I have done hundreds of rectal
Yeah.
exams and not even a single patient, even people who come in with incontinence have made a
Yeah.
mess. So
Right.
don't worry about it. And even if you do, it's a doctor's office.
Okay.
Don't worry about
Yep.
it. So you have to kind of like really take them in confidence and, kind of
Mhm.
put them at ease. And I sometimes tell them, this is what I would like to do.
Yeah.
Think about it. We don't have to do it today.
Mhm.
So sometimes they're like, okay, maybe next visit
Yeah.
or in a couple of sessions. And it's totally fine. Like, let
Mhm.
them decide when they are ready for it. And I think the
Yeah.
outcomes are always a lot better when they come and say like, okay, I'm ready for it.
Yeah.
You know, so that's one thing. But obviously, a gloved finger, and usually,
Mhm.
like the index finger, it's usually poop is much bigger than this, so
Yeah.
you're not going to be able to get hurt. And obviously, I will be even more careful with someone with LS, because
Yeah.
if they have history of fissures, or a fissure is
Mhm.
healing, in the process of healing,
Yeah.
I would even say that you're probably let's not do it right now, because
Okay,
I
interesting.
don't
Yeah.
want to irritate a tissue which is already kind of inflamed.
Yeah.
And I've said this, like, I then in those cases, let's work externally, do some breathing exercises. I'll show you some stretches,
Mm.
and come back when the fissures are healing, and then we'll do it. Because no matter what, when you know that there is a fissure and there is pain, and I do a rectal exam, also, like, all of the patients say like, okay, this is going to be very painful, because generally speaking, their experience has been just finger being shoved up. So
Right. Yeah.
it's very sad that they don't have an agency and talk about like, can you go slow? So I
Mhm.
usually tell them, I put ton of lube on my
Yeah.
finger. I put a little lube on their anal sphincter to begin with, so the passage becomes easier. And
Mhm.
I am in no rush to enter my finger there.
Yeah.
Kind of like, I tell them, my finger is on your anal sphincter. Is it okay to start
Yeah.
now? And then they say, yes, they're ready. But I'm already feeling a lot of tension clenching at their anal sphincter. So I
Mm.
tell them, pretend that you are pooping. If they clench even further, then I know that they would be tight inside. There
Yeah.
is no point of further
Right.
aggravating it.
Right.
So we may have to start even more gentler, doing some
Interesting.
massage around the perineum, massage around the sit bones, do some mobility for glutes and hamstrings, tailbone exercises to finally improve the overall flexibility of the area.
Mm.
Once they feel more comfortable, and I repeat this exam, sometimes I say, okay, I don't think I should go any further, because this is going to hurt more and it would not be helpful. So you have to make those clinical judgments as you're doing it. It's not like, okay, I have the finger, a glove on my finger, so I am going to have to go now. It's not like that.
Mhm. Yeah.
And you can also stop your PT or your
Yeah.
doctor at like, okay,
100%.
I don't think this is going to go well, so please,
Mhm.
I'm not comfortable. But then if they're able to even relax the sphincter even a little bit, then I kind of like go very little by little, half a
Mhm.
centimeter, half a centimeter, and then I'm kind of like doing a little massage on the sphincter to release it. I'm
Mhm.
asking them to breathe and keep on relaxing as much as they can. I sometimes say tighten, squeeze it, and then let go. This kind of gives them further idea that, oh, they were actually tensing up, but this motion kind of gives them a little feeling of how to relax. And then I go
Mhm.
a little bit further in. And then again, like, really respecting the tissue. If the tissue is really tense and tight and it's not letting me put my whole finger inside, and it's totally safe.
Yeah.
People have anal sex, so you can imagine like a finger is just nothing.
Mhm.
So uh, really respecting the tissue, and just it's allowing me only this much movement, and it gives them plenty of feedback to really
Yeah.
feel what's happening with their pelvic floor. Even that is good to start.
Mhm.
And then in less severe cases, you could go all the way up, and it's like, do you feel this? It's so hard to kind of pull away this muscle with the finger. So we try to stretch it out towards the tailbone. Let me show you. So it's almost like you kind of put this here, and then you're kind of like stretching it out towards the tailbone. So you see, like my finger is going away from the pubic bone.
Yeah.
So this muscle goes from here to here, but if I push it away, I'm stretching it.
Got it. Yeah.
Very, very gently. And
Of course,
usually it responds. Sometimes it doesn't. So we have to just kind of like make amends as we are doing this treatment. So that's the basic exam, how we do the digital exam when someone comes in.
Right.
We can, if you have any questions, we can talk about it, or we can go into like what they can do. What are the exercises?
Yeah. I think I just want to mention that, like, for me personally, I really appreciate biofeedback. I don't know if that has to do with the type of learner I am, but even when I got dilators, I wanted the PT to show me how to use them on me so that I could understand what I'm supposed to be feeling. And it just really enhances the education aspect. Not that I'm saying like everybody drop what you're doing, go get a rectal exam, but it can be beneficial to really understanding and becoming more connected with your body. So thank you for spelling that out. I think that's really going to help people, again, just feel more confident when they get in there, because they kind of know what's going to happen or what can happen, and knowing that they have the choice to, at any point, say, no, we're going to stop this. I think that's a really important thing to emphasize. People kind of think that when you're doing an exam, you just have committed and consented for the whole thing. Consent can always be revoked. At any point you don't feel comfortable, you can speak up. So great. Let's talk about techniques. What kind of exercises do you do for patients? And I'm sure that might differ based on the type of constipation, so maybe just keep it a little bit more general.
Great. And actually, one of the really cool and easy and cheap biofeedback device is a mirror, a handheld mirror. You can just point the mirror to your perineal and anal area, and just kind of like check if you have that ability of expansion. You'll see the anus moving with exhale and puckering in as you contract it. And it may take a while to, just for some people it could be triggering. And it took me a while to think and understand it, that not everybody wants to look at themselves like that.
Yeah.
But I'm sure with, people, if we're talking about specifically lichen sclerosus, as you mentioned a lot about, monthly vulvar checks. So I'm sure people are familiar with this, like, checking themselves out with the mirror. So they could also check, like, what is their ability of their pelvic floor to expand and contract. And they will, with pooping, as you're expanding, you'll see a mild bulge in the perineum as you are expanding the pelvic floor. So that could be, like this area kind of bulging out a little. So that's what we want to see. So the exercises. So since it is the back part of the pelvic floor, you can do the typical pelvic floor relaxation exercises, happy baby, child's pose with the knees open. You can do all those things that you typically do to keep your pelvic floor happy and healthy with lichen sclerosus. In terms of constipation, the only slight difference that you could make in your stretches is to open the back part of the pelvic floor. So let me show you this. So as you can see, the pelvic floor is basically sitting in this hole. So for the back, to open up the back part of the pelvis, you need to move your hips internally. I don't know if I can really quickly explain this, but I'll try. So you can see the hip bone is sitting inside the socket in the pelvis, and if you externally rotate the hips, it opens up the front part of the pelvis. Like, I mean, it doesn't move so much, obviously, but just for the sake of explaining things, this external motion opens up the front part of the pelvic floor, and then internal rotation of the hips. Oh my God, this is so out of control. To kind of this internal rotation opens up the back part. So what is internal and external rotation? If I have to show you on my legs, it's basically internal is when you're going in, external is when you're going out. So doing the same stretches like happy baby, cat cow, you could keep your knees slightly together and feet apart, which put you in an internally rotated hip position, which opens up the back of the pelvic floor. I have a series of exercises which I have put specifically for constipation on my Instagram page. There is a section highlights of bowel health on and the highlight section.
Stories,
the stories, and you can check it out. Another thing that people can do is using a squatty potty, because squatty potty puts our pelvic floor in a nice position, specifically for, again, puborectalis, keeping the knees slightly higher than the hips in that kind of like a squat position, which many people, historically speaking, a lot of Asian countries still do that, like the squat, because it relaxes and opens up the pelvic floor and creates this top pressure from, because you're kind of sitting in a slightly flexed position. So it helps with increasing the pressure from top and opening at the bottom. The squatty potty is great. Then fiber and hydration is always a great idea. However, people think fiber is going to resolve all the issues. For some people's gut, different types of fibers work. If you are having insoluble fiber, which is kale and present in some green leafy vegetables, it can add too much bulk and give you bloating and may make it harder for your poop to move forward. Some soluble fibers like psyllium husk could be great. And again, like, I'm not speaking for soluble versus insoluble. People may have different needs. I am not an expert on that. Please speak to a dietitian who understands these things, and you could experiment a little bit. We always like, okay, it's only food, we can figure it out. But sometimes professional help can go far.
Or speed up the process significantly, because I've definitely tried to figure it out on my own, and at one point I was just like, okay, like, this has been months, I'm just gonna find somebody, because I don't know what to do with this anymore.
Yeah, totally. Then movement and exercise, just kind of like think about it, and this is more about the mobility and motility of your own gut. So if you're doing brisk walking, some cardio training where you're getting a lot of movement of your trunk, can really stimulate the gut to move things further along. It can also relax your pelvic floor muscles and the abdominal muscles, or wherever you're holding tension, because movement is the best antidote to any fixity in the system, any tension we are holding and clenching. So you can do that as well. Some yoga stretches where you're kind of rotating the torso, like arm goes one way and the legs go the other way, are really good for the churning up things, as I call it. You're to move things along in your plumbing. So for pelvic floor health, we already talked about, a little bit, like doing some breathing exercises, opening of the pelvic floor in the back part mainly could really help with relaxing these muscles. Becoming aware of your own guarding mechanisms where you hold the tension. A lot of people in New York City clench their buttocks. This is our coping mechanism here. And when they become like, I don't know why I do that. I've started noticing, yes, you're right. And jokingly, sometimes, we call them anally retentive. A lot of us are
Right. Yeah, I haven't heard that term in a while.
One of my lawyer patients is like, yeah, I think people call me anally retentive for no reason. I was like,
right.
Yes, that's correct. I love that when patients take it lightly and come with some sense of humor. It helps so much.
Mm-hmm.
Okay, so that's that. Then spoke about exercises, specific exercises to work on the back part of the pelvic floor, breathing, hydration and fiber, squatty potty. Then one of the things that I want to talk about is the gut system is a creature of habit, and which means is that it has a rhythm, and it's really tied with your circadian rhythm as well. So sleep hygiene is super important for having bowel movement on a regular time each day.
Yes.
It could be very frustrating for people, and again, like I have experienced this as well. Like, I don't have time today. I have my first client is at 8:30, and I'm just like getting ready, and I'm not a morning person, so the day I'm not able to go. So I have that opportunity, or like I'm grateful for this, that I can schedule my clients in a way that I get my morning time, and everything is fine. It's a digestion and elimination are parasympathetic nervous activities. So the more we stay calmer, doing breathing exercise, and again, like I'm not specifically saying, you can't be stressed. Stress is a part of life, but knowing how it is affecting our body and taking steps at the right time could be very important. So I kind of I suffered with constipation for a very long time. Actually, started as a kid. I was always constipated. So I don't know if age helped me or fiber, what helped, or maybe running, because I became a runner in my early 30s. All of this was helpful. But the thing that I think helped me the most was having a ritual in the morning where I would get up and like have coffee, or go for a run, then come back and have like a decent amount of breakfast, which stimulates the gastrocolic reflex, which literally means that our gut is getting a message from our stomach like, hey, oncoming traffic, empty out. So there is space for more stuff to come. So it can get really activated in the morning times. It takes about 30 to 40 minutes after having a meal. So you could eat something, go for a walk, then kind of like do a couple of breathing exercises and stretches, and you're like, oh, there is the urge. I can really notice it.
Right.
And you go to the bathroom and relax your pelvic floor using squatty potty, and you should be able to go. So that's pretty much the whole system works. I know I made it sound very easy and straightforward, and people can have difficulties at different steps of the way, but kind of like creating a ritual can give you a little sense of what is the difficult part for you, where you might need more help or time to assist your system to eliminate, basically.
Yeah, that's interesting. That makes a lot of sense, because I have a very consistent sleep schedule when I'm at home. And I have a very consistent poop schedule. And now I'm starting to see that there might be a connection there. But I've noticed that when I travel, that's when it gets disrupted. So I regularly go every single morning. And then I travel, and it's like my poop does not know what to do anymore. It doesn't know where to go. And I think I attribute that to the sometimes very drastic sleep disruptions, like when I go to Europe and there's a big time change, but then just being out of that ritual that I usually have going in the morning. So that makes a lot of sense.
No, jet lag, circadian rhythm, these things can not having, again, our favorite toilet seat, the height of the toilet seat is different.
Yes, yes,
I don't
yes.
have squatty potty. My legs are dangling. I don't know what to do. If I'm going to a conference and I have roommates, I don't want to make sounds.
Oh,
There could be
yeah.
so many
Right,
things.
right. Because if you want to do
Yeah,
like the moo or something, that's
yeah,
a
yeah,
little
yeah.
strange if you've got, one of your colleagues in the next room. I mean, maybe not at a pelvic floor conference. They might be like, good for you. But,
Yeah, they're like cheering for you from outside. Like, yeah, we'll move with you.
woo, yeah, no, that's great. But we're not all going to pelvic conferences. So, yeah, it might be a little strange sometimes. So this is really great in terms of exercises and lifestyle management. And I would assume that, once we're kind of discharged as patients or things have kind of resolved and regulated, when we go back, now we're just kind of back in the real life, no more PT sessions. We just want to continue with all the things that we learned, right? Like all the different types of exercises and breathing. That's something we want to continue on to set ourselves up for success, correct?
That's absolutely right. And I did not mention, but people can use the other side of the pelvic wand for people who have used it to stretch the muscles, to kind of give yourself a little feeling of how this muscle is supposed to open up in between the sessions as well.
And you would demonstrate, you could show us like how to use that, right? Because I feel like intuitively, I know what a wand looks like, and I'll pop one up on the screen. But I feel like I'm trying to picture, like, I don't know how I would do that.
I totally forgot to keep it out. Yeah, but it's good to kind of show this as well. So this is the thinner end of the wand.
Yeah.
And you're basically, I will detach the superficial layer. So kind of slowly go in, ton of lube, go in, and you're kind of like just doing a little bit of pulling on tugging on the muscle. And again, like, it's not like you're just pulling apart things. It's going to be very painful. It's very gentle, kind of like giving more of a sense to the muscle. Hey, look, you can actually expand. You don't have to stay in this tense position. As you're practicing breathing, or as you can also do a little bit of pelvic tilting with it, so you can give an external cue to the muscle and keep the wand steady, and you're kind of like doing movement with the pelvis.
Got it.
So a PT would explain to you how to use it, or even if you're ready to do it on your own.
Yeah.
And you could definitely practice it.
Yeah, because I'm the type of person where I would bring my wand in to our session and be like, hello, Mukta, show me how to use this, because I don't know what I'm doing.
And also, like, there are different kinds of wands, nowadays with vibration and stuff. The wands that you can kind of cool, put in the freezer first, or heat, or whatever works for you. Again, there is no right or wrong answer. What we are trying to achieve, the objective is to give the muscle the feedback that it needs to expand. And insertion of the wand could be a little difficult. Sometimes I tell my patients, like, you actually, what's tight for you is just the sphincter. You don't need to buy a wand for it. Just put a glove on your own finger and just massage around the external sphincter. That's all you need to do. And most of the times that kind of like takes care of the issue for them. It really depends. Like, we have to kind of like check. That's why assessment is important. Is it the pubic rectalis? Is it the superficial muscles? Especially because, let's say, if your problem is not super advanced and you're just experiencing some, lichen sclerosis around the perianal tissue, and that's causing some just clenching of the anal sphincter itself. So kind of like just massaging that part could be more than enough for you to help with your bowel movement.
Interesting. Yeah. And I would assume for that there's a similar caveat for the rectal exam, such that if there's a fissure or some kind of open sore wound around that area, you would wait for that to heal before doing the massage, right?
Absolutely.
Yeah.
Absolutely. Which goes
Yeah.
for any kind of tear. Like we don't want to disturb it.
I was gonna say that's no, I would imagine that's not exclusive to lichen sclerosus. Any kind of open wound we generally want to let heal before working on the tissue. So that's perfect.
Yeah. And here's the thing, like, you still have to poop with maybe a fresh fissure, and that kind of can keep on getting irritated. So sometimes some of my clients, sometimes you learn different kind of practical advice from people who are actually experiencing pain. And I think a couple of my clients told me that they put Vaseline on the anal sphincter before they go poop, which kind of helps with the elimination, and it kind of like creates a little covering on the barrier on the fissure as well. So that's another thing that you can do.
Yeah, I actually do that because that's part of my issue. I would notice like, okay, I have a fissure, but it would just never heal because I have regular bowel movements daily, and I tried to not, but that's not a very good solution, and it really doesn't work. And I just felt like every time I would have a bowel movement, it would just open it right back up. So I was like, how am I going to heal? Like if I still have to poop, right? So I started doing that trick as well. So that's definitely a good one. Before we kind of wrap things up, I do just want to let people know that when it comes to post bowel movement cleaning, when you have lichen sclerosus, I don't know why this took me so darn long, but I recently got a Tushy bidet that I installed. I don't know why it took me this long. I have been plagued with fissures and hemorrhoids and all of this. I don't know why it took me so long to make this call. And it's not like I didn't know this was a thing. I really don't know why I waited so long. But it is a life changer, because if you have, and like LS skin can get very irritated back there. So even if it's not a fissure proper, when you're taking toilet paper and rubbing and tugging on that skin, which can be really fragile, really irritated, you're only adding more irritation, more pain, more discomfort to it. And so getting this bidet installed, I mean, my husband installed it, but it's quite easy to install. And
I installed it.
Oh, did you?
Yeah.
Good on you. Yeah. So it's apparently, they say it's really easy, really intuitive to install. And then once you got it, that's just what you're using to clean back there. And it can be really helpful if you have irritated skin. So that's just like another pro tip from someone that's living with this and struggling with it.
I love that. Yeah. I love that. And I'm so used to it now that when I have to just like use just a towel. I mean, I grew up using a bidet.
Of course, yes.
I mean, water. We don't use just toilet paper in India. So it was very hard to get that adjustment. And it's like finally we have this accessible. So I installed it as soon as I could, and it's life changing. It's just like, oh my really God, it feels so good. And I, especially as I'm pregnant right now, and I am noticing like, all these constipation and all these hemorrhoids and whatnot, it kind of comes back. And sometimes I get fissures as well. It's been really, really helpful to have that.
Yeah. Again, I'm just like, I feel like I need to tell everybody about this now, because it really changed my life. And it's so true when I like go to a conference or go to somebody's house and they don't have one. I'm like, how am I supposed to have to use toilet paper?
Yeah. Wow. And like for travel, people can keep a peri bottle.
Yeah, I was going to say peri bottle. And actually, Tushy just launched. They have like portable Tushies now that are like their version of a peri bottle. And I was like, well, take my money.
Okay. All right.
I'll be getting that. I just saw that on Instagram the other day. So I was like, well, that's a must. Okay, before we close out, is there anything that you wanted to say on the topic of constipation and LS that we missed, that you wanted to mention?
That's what I'm checking. I think spoke about everything that I wanted to say. Yeah.
Great. And then, so if people want to follow you, where can they go?
I used to be pretty active, but I still have a lot of content that you can see on Instagram at the pelvic dot connection. Like I said, I have a highlight of bowel health, which has ton of resources, exercises, and explanation of how the system works. And somehow I end up just like, I'm a couple of great, amazing dietitians as well that I made friends with on Instagram and have learned a ton from them. One thing that I want to say as we are wrapping up is beware of all the diets that you just hear from social media or Google, because this is what I learned from my dietitian friends, that disordered eating is very common in our culture and society. It may not be an full-fledged eating disorder, but I realized how much disordered eating I was, having, and kind of like, it's not always about the food. It's about how your nervous system is working, how your pelvic floor muscles, musculoskeletal system is working. So many things go into having a healthy bowel. It's not just about the fiber. It's not just about the food you are eating. So don't beat yourself up if you're like, oh God, like, I'm not having definitely improve your diet if you think you're eating a lot of processed food. But if for the most part, you're having a good diet, like, don't really beat yourself up. Food is there to enjoy as well.
I 100% agree with that. Well, thank you so much, Mukta. I learned a ton. I am so grateful for you as always, and just really appreciate your time and all the things that you do to give back to the LS community.
I'm very happy. I just love to talk about poop. So let me know next time.
And I love to learn about poop. So it's a great match.
Perfect.
All right. Well, thank you, everybody. That's it for this video. We will catch you in the next one.
Thank you.
Bye.
Bye.